Good morning, good afternoon, everyone. Thanks so much for joining us today. We're very excited to be sharing with you the Models of Care Toolkit. My name is Natalie Fitzgerald. I'm the Director of Performance at the Canadian Partnership Against Cancer. This toolkit really wouldn't have been possible without all of the support and collaboration with so many of our partners. In particular, I'd like to thank our co-leads from the Saskatchewan Cancer Agency, our Models of Care Expert Advisory Working Group, and the many clinicians, health system leaders, patients, and family advisors who helped shape and deliver this toolkit. I'd like to start off today by acknowledging where my feet are. I'm currently working out of my home office in Chatham, Kent, in southwestern Ontario, which are the traditional lands of the Three Fires Confederacy, the Odawa, Potawatomi, and Ojibwe nations, and the current home of the Delaware Nation. This land was settled through the McKee Purchase Treaty of 1790, with mutual agreements by all to take care of the land and the water. My family and I enjoy spending time outside exploring the many different parks across Chatham, Kent, from the shores of Lake Erie to Lake St. Clair and the Thames River that runs through town. We're so grateful to those who have preserved these places, which are home to many birds, trees, and plants that are unique to this area. For those of you familiar with Chatham, Kent, you may also know this is part of southwestern Ontario, is considered prime agricultural land, sometimes referred to as the Banana Belt. Chatham, Kent claims to be the #1 producer in all of Canada of tomatoes, seed corn, Brussels sprouts, and cucumbers, among many other vegetables, largely attributed to the rich soil, warmer temperatures, and just the right amount of precipitation. But we have not always upheld our side of the McKee Purchase Treaty to take care of the land and the water. Colonial ways of farming have desecrated the lands, deforesting almost the entire county. Chatham, Kent has among the lowest tree canopy in Ontario, just above 3%, as you can see in this aerial view. Where you see the darker green spots on the map, this indicates where there's more tree coverage, where the forest still remains. There's not a lot left, and not coincidentally, those areas are where Moraviantown and Walpole Island are, which are our First Nation communities. The importance of the environment and preserving the land and water for generations to come is core to what it means to be stewards of the land. They know how important it is for their health and well-being to protect the forests, the land, and the water, and that knowledge comes from within their community. As we hear more today about the Models of Care Toolkit and think about innovative approaches to redesigning the cancer system, we need to be mindful that those who we are serving, their knowledge comes from within their communities. First Nations, Inuit, and Métis communities have been stewards of the land as part of a holistic approach to health, and they know what they need. As a non-Indigenous organization, we can steward the cancer system by enabling self-determination and creating space for others' voices to be heard. Through co-creation and authentic engagement, we can reimagine a cancer system that better meets the unique needs of people across Canada. And as part of that commitment going forward, we will be working with First Nation, Inuit, and Métis partners to identify Indigenous-led self-determined models to add to the toolkit, as well as supporting the implementation of Indigenous-led and Indigenous design models of care in the future. Without further ado, I'd like to introduce my colleagues, Cynthia Nielsen and Erica Brown, who will walk us through today's presentation. Cynthia is a manager and Erica a lead in the diagnosis and clinical care team at the partnership. Just before they begin, a reminder that today's session is being recorded and the recording will be posted after to the website, and you're welcome to share that with colleagues and your networks. As this is a Teams live event, your video and microphones are disabled, but you're encouraged to use the Q&A function on the right-hand side of your screen to send in any questions or comments, and our moderators will do our best to reply in real time. We also have some time at the end for any discussion. And if you have any lingering questions after today's session, there will be an email address shared at the end of the presentation, so please don't hesitate to reach out. So with that, I will pass it over to Cynthia.
Thanks, Natalie. So today's webinar will describe how innovative models of care can improve the efficiency of high quality care and enhance health equity. We'll describe the models of care included in the toolkit and how they're working across Canada, and describe how patients, cancer care teams, and community groups have been involved in the models of care work and how they can benefit. We thought it would be helpful to start by defining health equity. At the partnership, we define health equity as being created when individuals have a fair opportunity to reach their fullest potential. Achieving health equity requires reducing unnecessary and avoidable differences that are unfair and unjust. Many causes of health inequities relate to social and environmental factors, including income, social status, race, gender, education, and physical environment. To kick us off, we wanted to define a model of care and provide you with an example of the benefit of a model of care for a patient living in a rural community. A model of care is defined as the way health services are designed and delivered for a person as they progress through the stages of a condition, so for example, cancer. For patients living in rural communities, accessing care in the traditional model, which I'm describing as focusing heavily on treatment, where treatment will be focused at a cancer center provided by oncology specialists, can be challenging as there is often an undersupply of specialists living in the local area. This means patients often have to travel quite a distance to access in-person care from specialists. To illustrate this challenge, I'd like to read a quote from a patient with cancer in Northern Ontario. So you can see the quotes on the slide, but I recognize it might be small for some, so I'll just read it out. The treatment for cancer is sometimes referred to as a full-time job. I can say that it's a job and a half when you live where I do because it's pretty difficult here in the north. I live some 200 kilometers from where the treatment is actually performed. In the orange box on the slide, you'll see the potential opportunities for a new model of care where patients can be seen in person at the cancer center, but where appropriate, they can also access care in their local community through their primary care provider or through a virtual clinic that connects back to the cancer center. Optimizing the role of non-oncologist team members, enhancing coordination between cancer care and primary care, and optimizing the use of virtual care solutions can all support better access to care closer to home for patients living in rural communities. An impetus to this work that started in 2018 at the partnership was hearing concerns from our cancer program partners regarding the rising burden of cancer, increasing expectations for person-centered care closer to home, and the imperative to reduce inequities in delivery of care and health outcomes. All these concerns put increased pressure on the cancer care system and providers, resulting in staff shortages and attrition, which further compounded the problems. In collaboration with cancer programs across Canada, we identified two key pieces of work that were expected to help us identify the scope of human health resource challenges across the country and then identify solutions. The first was to analyze physician and technical resources used during cancer treatment with cancer incidents. This was done using geomapping to better understand human health resources. The second was to identify models of care that support efficient delivery of scarce resources. We did this through the development of a Models of Care Toolkit, which Erica will be walking you through shortly. Concurrent to conversations about human health resources, the partnership is working with our partners and all people living in Canada to refresh the Canadian strategy for cancer control. In these conversations, we heard again and again how innovative models of care could be used to help diagnose cancer faster, help us enhance the quality of care that's delivered in Canada in a way that better supports patients and their families and encourages self-determination when making care decisions. We can all agree that the world is a different place now than it was in 2018. The pandemic has put unprecedented stress on the healthcare system, but through this crisis, we've seen new innovations in how we care for and support patients. We've also begun to think about how we support and engage equity-deserving communities, working with our partners to find new ways to tackle problems and help bring all voices to the table. You'll see many of these themes woven through the content of the toolkit that Erica will be presenting next. So with that, I'll turn it over to Erica.
Thank you, Cynthia. So this is the Models of Care Toolkit that we launched in March to help cancer programs address common issues within the cancer system. We focused the work on three key areas. The first, models that enhance coordination between the cancer system and primary healthcare, including diagnostic pathways and rapid referral services, connected care models for patients transitioning out of active treatment, and integrated palliative care. Models that optimize the scope of practice for nurse practitioners and clinical practitioners in oncology, including distributed care models and community-based chemotherapy models. As well, networks and clinic models, which have been shown to enhance person-centered care and healthcare provider resiliency. The toolkit also includes information on how cancer programs can support Indigenous-led models, considered a critical step towards achieving health equity. Virtual care and patient navigation have also proven to enable successful launch of person-centered models of care. We've included some examples of these innovations in practice and some resources for programs looking to enhance virtual care and navigation programs within their jurisdictions. To help programs take a holistic approach to implementation, we've also included tips on administrative, operational, and cultural considerations that can help during the planning phase. Things such as health and human resource considerations, remuneration strategies and approaches, and change management implementation that can be considered to help enhance the success of these models. I'll now do a bit of a deep dive into the different sections of the toolkit. The first priority was to find models that enhanced coordination within primary care. Improving coordination at this critical stage of a patient's journey can streamline their diagnosis and help them feel better supported by all members of their care team. From a system perspective, enhanced coordination during the early diagnosis phase can improve efficiencies by reducing redundancy in testing, follow-ups, as well as a reliance on ambulatory services. Our first model in this section is a diagnostic pathway or rapid referral service, which can help primary care providers guide their patients through the cancer diagnosis process. The Denmark model, spotlighted here, included in the toolkit, has been especially useful for patients with non-specific or undefined symptoms and provides clear guidance and resources for family physicians, enabling them to support their patients through this critical and often stressful time in a patient's cancer journey. This section of the toolkit also includes models that support the integration of palliative care and provides examples of novel approaches to care delivery within the community. On this slide is a spotlight of a multi-provincial initiative supported by the partnership and our partner, Healthcare Excellence Canada, that equipped paramedics to deliver palliative care to patients at home. Clinical practice guidelines and paramedic-specific education are coupled with a tool to share patients' goals of care between paramedics and the rest of the multidisciplinary team. These were seen as critical elements of the model and a key to their success. In addition to decreased use of emergency departments, empowering paramedics to provide care in patients' homes reduced their time per patient, resulting in an overall cost savings for the system and an improvement in person-centered care. The second toolkit priority is optimizing the scope of practice to better balance work pressures, support career development and satisfaction among staff, and provide a more responsive care and connected care for patients. Our discussions with cancer programs highlighted the potential for optimized scopes of practices in several professions, such as nurses, pharmacists, advanced practice radiation therapists. We've initially focused on nurse practitioners and clinical practitioners in oncology, but plan to expand the toolkit content to others. In addition to helping staff address shortages and burnout, optimizing the scope of practice can help support continuity of care and enhance access to care for patients living in rural and remote areas. We've also included advanced practice and education resources that might be useful for cancer programs as they look to change scopes of practice within their teams. The next few slides highlight a new program launched in Alberta and focuses on the scope of practice for nurse practitioners. Within the province, about a third of cancer patients are cared for in community cancer centers located at rural hospitals. For patients getting chemotherapy, this has traditionally been overseen by a general practitioner with specialized oncology training. A persistent shortage of GPs in rural Alberta has made it harder for these community cancer centers to find GPs to manage this care. Recently, the province has invested in nurse practitioners, and now all tertiary and regional sites employ specialized nurse practitioners. With similar scope of practice to GPs, it was thought that these specialized nurse practitioners could be trained to support chemotherapy supervision. In this model, nurse practitioners work with medical oncologists at cancer centers in Edmonton or Calgary, clearly establishing a mechanism to communicate patient protocols and status, while also serving as a coaching tool for the nurse practitioners. In the model, nurse practitioners connect via telehealth to the site for a weekly clinic. Registered nurses at the community cancer centers participate with the patient in the virtual nurse practitioner visits. A registered nurse-led clinic was also integrated for patients who did not need to see nurse practitioners at each visit. In addition to supporting care closer to home for people living in rural and remote areas, local teams are best positioned to understand the context of community supports and have been shown to connect their patients more quickly to the services needed to support their care, such as complex pain clinics and psychosocial and nutritional supports. The provincial cancer team recognized that simply adding this new work to nurse practitioners wouldn't ensure program success and wasn't the best way to support their staff in this new work. They allocated resources to support change management, both at the tertiary and community centers. This included advanced practice nurses to help coach nurse practitioners in clinical decision-making, staff educators to support new skill development, the on-site care team, a transition team to support new workflows for the effective transition of patients from the tertiary center back to the community cancer center, and engagement of both local and provincial operational leadership to provide guidance and coaching to overcome any barriers at the system level. The model was piloted at one community cancer center and is now being expanded to other centers within the province. While initiated before the pandemic, models that innovate virtual care became extremely essential when in-person care was impacted by lockdowns. Alberta's approach helped reduce the need for vulnerable patients to travel to receive care. It kept them within their community where they had support systems and could minimize interactions with others. When tertiary centers were overwhelmed with ambulatory needs related to COVID-19, this approach also helped address bottlenecks in the system. The province has seen care volumes increase at the community center since the model has been implemented, and with patient outcomes and nurse practitioner job satisfaction having been improved. Close collaboration between community-based home care and palliative care resources has also improved coordination as a patient's illness progresses. Previous to this new model, no referrals to palliative home care were initiated from the pilot center, and this is now being done as a matter of routine. How cancer services are organized within and between cancer centers can impact the access of high-quality care for patients. In the Cancer Care Network section of this toolkit, we've included models that can help enhance access to specialized care in rural and remote areas of the country and can help cancer programs coordinate patient care to make receiving care more convenient for patients and more efficient for cancer programs. Cancer networks can take many forms and are commonly organized for a specific disease site. This model in the toolkit shows that they often connect 2 or more centers that share clinical expertise, resources, and services. Networks can provide a structure for staff to work more closely across jurisdictions, across institutions, and across professional boundaries. This type of model helps support the flow of expertise and best practice. It improves the quality of and access to care for patients, including those who require coordination of care from various settings or across various professions. The network model can improve timely patient access to specialized expertise, especially in rural and remote areas where traditionally they've had to travel to a tertiary center. It can also promote knowledge sharing among providers across sites and lead to improved standardized protocols and homogeneous practice. Alberta's nurse practitioner-led virtual care example that I mentioned earlier is an example of a network. Another is Quebec's Cancer Network, which was piloted in lung and is now being applied across all disease sites. Within Quebec's cancer networks, these networks organize care and service delivery around specialized and subspecialized interprofessional teams. And it has been shown to enhance access to special care, as I had noted, within those rural areas. The addition of a quick access desk has been shown to streamline the diagnosis and treatment planning phases, and it has promoted continuous learning among all staff at all of the centers involved in the network. A second model included within this section are multidisciplinary clinics. These clinics use an integrated approach to planning and delivering services across specialties. Nurse navigators in these models can work with patients to coordinate their care on a specific day. This allows patients to come to the cancer center once to meet with their radiation oncologist, their medical oncologist, a pharmacist, and any other allied support specialist they may need to see during the course of their treatment. The Saskatchewan model that we have highlighted in the toolkit is an example and also had included as a success measure workflow procedures that help support access for patients living in rural and remote areas. And the addition of in-person and virtual appointments within this clinic structure help facilitate access for patients even during the pandemic. As I had mentioned earlier, our consultation and research identified virtual care and patient navigation tools as being particularly helpful in supporting equitable access to care for cancer patients. In the toolkit, we've included some examples of how innovations in these areas have been implemented across the country and resources for programs looking to do the same. I have to go back a slide. Let's see if I can do that. During the pandemic, we've seen a rapid uptake of digital health solutions. And while the health system is shifting from pandemic response to recovery, we don't expect to see a leveling out of these approaches to person-centered care. I've given a spotlight on this slide to Opal, a mobile phone application developed and used in Quebec. Using the app, patients are able to report symptoms to their care team before each visit. Care teams can review results and use them to determine whether an in-person visit is needed or whether the patient could benefit from other care supports, such as psychosocial or nutritional counseling. The final spotlight I want to share is a First Nations-led patient navigation program developed as part of the Nova Scotia Aboriginal Home Care Project. Within the province, many First Nation people living on reserve were not having their discharge planning needs addressed adequately. Many who returned home to the reserve after a hospital stay were not having their care needs communicated to band employed nursing staff because no such protocol existed. This communication disconnect resulted in unnecessarily long waits to be discharged, frequent readmissions, and high complication rates. The model helped patients get a functional assessment pre-discharge, connected them to short-term care service until a community coordinator was assigned. Evaluation of the model showed improved patient outcomes, fewer readmissions, and improved collaboration between the hospital and First Nations community. I like this model because it highlights how a system can benefit when it listens to the needs of the community it serves and empowers that community to not only participate in, but lead in the development of a solution. So that's the toolkit in a nutshell. As we walk through the priority areas and content, you may have felt that something was missing. During our consultation phase, we heard about a number of system-level issues where models of care could play a role in the solution, but we were only able to bite off part of that cookie. Innovation never stops, nor does our desire to learn from one another. We've already prioritized the addition of new content, including First Nations, Inuit, and Métis developed and led models, as Nat had mentioned. But if you see an area that you'd like to have addressed in the toolkit, please visit the toolkit website and tell us what you want to see. There's an email link included at the bottom of the main landing page, as well as the 3 priority page areas. I'm now going to turn this back to Cynthia for a brief discussion on what the partnership is doing next before we open up the floor to questions.
Thanks, Erica. Building on the development of the Models of Care Toolkit that Erica has just walked you through, the partnership will be working with cancer programs, agencies, and community partners to support implementing and evaluating models of care in early diagnosis, treatment, survivorship, and palliative care. Our goals are to support the implementation of models of care that advance health equity, efficiency, and quality of cancer care delivery, to increase collaboration between jurisdictional healthcare systems and community groups representing the interests of those who experience the greatest disparities in cancer care in Canada, and to support the implementation of new models of care that can address system pressures and support pandemic recovery and resilience. To help support the implementation of models of care with a focus on health equity, the partnership has a responsibility and commitment to bring our partners along on the equity journey. To implement models of care to help drive system-level change, the partnership will support partners to ensure the focus on health equity aligns with real challenges within the health system. We will champion mobilizing change with a focus on health equity by fostering community partner collaboration, and to understand how this work is moving the needle on health equity, including performance measures that help monitor system changes. Another way the partnership is supporting, let's go back a slide. Thank you. Another way the partnership is supporting pandemic response, recovery, and resilience is through the development of a digital knowledge product called The Road to Recovery: Cancer in the COVID-19 Era. This knowledge product aims to provide a compelling story for policy and decision makers to prioritize cancer among many competing pressures throughout the current and post-pandemic era. Similar to the development of the Models of Care Toolkit, its development was informed through an external expert advisory group and partner engagement. Key components of the knowledge product include current Canadian data showcasing the impact of COVID-19 on cancer, actions needed to support pandemic recovery efforts, and a selection of example solutions being implemented across the country. It also acknowledges that COVID-19 has not affected everyone equally, and existing health inequities have been further magnified by the pandemic. So this knowledge product will be available mid-June. So that concludes the formal webinar. So I'd like to turn it back over to Erica to facilitate our Q&A.